Well, good morning and welcome to the Epidemiology and Ergonomics lecture for AT200. And it may not be morning for you, maybe you're watching this in the evening. The point of today is to talk a little bit about epidemiology as well as some workplace ergonomics. So to get started, what is epidemiology? It's again the study of distribution and determinants of health-related states or events in specified populations. And the application of this distribution, determinants, and health-related states or events to control health problems. So pretty much you're looking at incidence, trends, distribution of injuries and accidents, and then trying to apply that to help prevent health-related problems or to control health-related problems. When you're doing epidemiology and you're looking at epidemiology rates, you're looking specifically at the frequency with which an injury occurs, and you're going to look at that over different venues, especially in the world of athletic training. You're going to look at sport-specific type exposures, practice versus games, women versus men, turf versus grass, or body parts. So you may want to look specifically at shoulder injuries in collision sports for women during practices, for example. Or you might just look at overall injury rates between practices versus games. There's a lot more exposure to injury in a practice because everyone's practicing for the entire practice, whereas in games, when you have subs and starters and you have different timeouts and plays, they may not have as many exposure to the injury situation. So you're really looking at the frequency with which an injury occurs, and can you see trends and things that happen throughout collision sports or contact or non-contact to help shape your practice. The research that's involved in epidemiological research is either large scale, but it could also be case study, where you're looking at specific cases of injuries and trying to apply how to control health problems to that specific case or that area of concern. Or you can do a large scale study where you're looking at the big picture, looking at a large scaled thing like high-risk sports or low-risk sports and looking at injury trends. When you're classifying injuries in epidemiological research, typically that's short-term, long-term, catastrophic, and sport-specific. Short-term would be missing less than a week, for example, or maybe a month, depending on the scheme of classification that's being used. Long-term might be missing more than a month. Catastrophic doesn't really happen very often in sports, but it is a serious thing that's happening, whether it's a neck injury, a head injury, or heat stroke, and so you'd want to look at the data and the rates for something like that to help prevent that from happening. And then, again, looking at injuries among sports-specific venues. So you might look at injuries among volleyball players or injuries among football players or different types, again, collision, contact, non-contact. Also important during epidemiological research to make some definitions and make things very well known that are specific to your study. So what is considered to be a reportable injury? If I'm looking at lower extremity injury rates with volleyball players, well, what is considered to be a reportable injury? Does that have to be something that is determined by time, by grade, by how long it takes them to return to play? You're going to have to determine what do you consider to be a reportable injury. And that might be, as it says here, damage to the body that restricts activity or causes disability to where the athlete's unable to practice or compete. So you just have to just define that or understand what the study is using as their definition for a reportable injury. And then, how do you define athlete exposure? First of all, the athlete has to be exposed to the possibility of injury. So you can't look at research where the athletes aren't even exposed to injury if you're looking at the incidence of concussions in golf members. Well, concussions don't really happen very much in golf. They're really not exposed to that injury, so obviously the concussion rate in golf is going to be low, but that's to be expected. Also, are you looking at reportable injuries in practices, games, conditioning, weightlifting, etc.? So the big question really is, what do you do with this information? You do epidemiological research and you look at injury rates among volleyball players to the lower extremity, well, what do you do with that information? And what you really do with it is that you might use that information to design protective equipment. Based on the injury rates, based on concussion rates in football, you might be charged with ensuring that your football players are wearing the proper protective equipment. You might establish or alter rules. And that's happening in the NFL all the time, right? Designing protective equipment to meet the health problems associated with concussions and skull fractures and head injuries, as well as establishing or altering rules where now you can't hit defenseless receivers, and as running backs you can't lower your head and hit the defender, as defenders can't lead with their helmet. They're being flagged and penalized for that, which is a lot different than the way it used to be 20 or 30 years ago in the sport of football, where it was really about injuring the other person if you could do that. And now they're trying to make the game safer, and they're making those decisions based on what the epidemiological research is showing. Parents, athletes, and coaches are going to constantly have questions about injury rates, distribution of injuries, incidence of injuries among the sports that their child is playing, or that the athlete is playing, or that the coaches are coaching. And so epidemiological research data can help to inform parents, athletes, and coaches about the trends and distribution of injuries in that sport. As athletic trainers, we like to use this type of research to provide rationale for priority in how we cover the sports that we cover. You know, if I've got a tennis match, a cross-country match, a soccer game, and a JV football game going on the same day, I can use the research, injury rates, injury incidents, and injury happenings to provide rationale for why I should be at the JV football game instead of the other three. And then ultimately to reduce the risk of injury. If I have data showing that these are the injuries that occur and I can put prevention programs or things in place to help reduce the risk of injury, then I'm doing my job even better. There are many injury surveillance systems out there, which are systems that are used to track injuries, like the NCAA injury surveillance system, which is number 2 on your bullet list. The NCAA gathers information from colleges all across the nation and puts them into a surveillance system, and then tracks that data about how many ankle sprains occurred this year, how many head injuries occurred, how many shoulder injuries, what sport did those injuries happen most commonly with, what severity were those injuries, how long were they out for. So these surveillance systems are almost like injury databases that track injuries, and then you can filter that information to use it the way you want to design prevention programs, alter rules, or all the things that I talked about on the previous slide, informing parents and coaches and athletes about the risk and incidence of injuries, as well as, again, provide rationale for the priority of why you're covering what you cover. It also helps us to determine what sports are considered to be high risk, what sports are considered to be low risk, but sports that have a high risk of injury, you're going to be able to confirm that through epidemiological research. You know, are there sports that have a potential for serious injury, a high frequency of overall injuries? Those studies help us to determine which sports are high risk. And as athletic trainers, we're going to have exposure to high risk, and specifically our athletic training students that are in our program need to have some exposure to high risk sports before they graduate. Because if that's where most of the injuries are occurring, we want our athletic training students to be in those environments to learn, as well as be well versed in the type of injuries that occur in those high risk sports, because most likely they're going to be working in those areas as they become certified and practice professionally. So I'm going to spend some time here going over just some of the stats and some of the things that come out of this epidemiological research, or some of the things that have been found to be important looking at the data of this type of research. One of the things that comes out of this research is that coaches play an extremely important role in preventing injuries, whether it's through teaching tackling techniques or preventing an axial load. And an axial load is really just when you lower the crown of your head so that you actually hit people with the top of your head. So there's this compressive force that's going through the top of the head all the way through the cervical spine, and that is a really big indicator of cervical spine injuries. So having our coaches really teach the tackling techniques properly by keeping their head up, preventing that axial load. The coaches spend more time with the athletes in tackling drills than the athletic trainer does. So we really see the importance of the coaches in proper teaching technique. We also find that there's a higher incidence of injury to the lower extremity than the upper extremity. Lower extremity is about 55% of the injuries for football, and upper extremity is about 23%. The most common injuries are the knee, and then the ankle, and then the head. With soccer, what's the most common injury? Well, its ankle is the highest, and then the knee, and then the thigh in women's, and then the ankle, then the knee, then the head in women's. And I think I just said that wrong. So ankle highest, then knee, then thigh with men's. And the lower extremity is about 70% of the injuries in men's soccer. So what's the most common? Well, lower extremity. But most specifically, it's the ankle and then the knee. There's a slight difference, obviously, as you can see, between men's and women's. And really, the prevalence of injury suggests a need for prevention, especially of the lower extremity ankle/knee injuries. In hockey, lower extremity injuries are more common than the upper extremity. 50% of player-to-player contact injuries, so there is a lot of contact in hockey, and that's where half the injuries are occurring, and then the other types of injuries are lower extremity. Field hockey, which is not a very popular sport here at Northern Arizona University. However, in the West, in California, and especially on the East, field hockey is a very popular sport. And again, seeing lower extremities as most common, and then other contact, such as game injuries, apply for 60%, and then 60% of the no contact injuries are happening in practice. In basketball, ankle the most common and usually seen during rebounding. ACL injuries are 60% non-contact, males and females, and if you recall back to the injury classification lecture that we had last week, there are non-contact ACL injuries, and 60% of the ACL injuries in basketball are non-contact, meaning that the athlete's not getting hit at all. They're just planting their foot and they're tearing their knee. And you can see in the lower left-hand corner, as that knee caves in on the basketball player, you can see that's a non-contact injury. Nobody's hitting her. She's just planting her foot and her knee buckles and caves in. And then 50% of injuries are through player contact. Gymnastics definitely have altered rules and made changes to the sport of gymnastics to try and alleviate the amount of injuries, especially in terms of how much they're arching their back. There's a lot of spondy injuries, or what's called spondylolyses or spondylolisthesis, which really just deals with a stress fracture in the low back as well as some slippage of vertebrae on top of one another. So those injuries are seen in gymnastics. The ankle is more common than the knee in practice, but the knee is more common than the ankle in competition, which is interesting. Why that is, I really don't know the answer to that. I mean, that would probably require some more research to see why is that happening. Lacrosse is very similar to soccer as far as the sport is concerned, but yet there's more upper extremity injuries in lacrosse, and that really has a lot to do with the stick and the throwing motion. If you've never witnessed a lacrosse game before, I highly encourage it. Very exciting to watch, very fast to watch, but very physical and a lot of contact in men's lacrosse. Getting hit with the stick, a lot of throwing injuries because it's like throwing a ball, so you're going to get those shoulder injuries. 45% of the injuries are player contact in male, and 55% of the injuries in females are non-contact, which makes sense because in women's lacrosse there is no contact. So there's not going to be a whole lot of contact injuries in women's lacrosse because there isn't contact allowed. Men wear a tremendous amount of equipment as far as their upper body. They wear shoulder pads, helmet, sometimes elbow protection, and they wear gloves on their hands. But their lower extremity is really not that protected because that's not where they're getting hit. Females, the only protective equipment that they wear is eyewear on their face, but no gloves, no shoulder pads because it's a non-contact sport. Volleyball, as you would suspect, the lower extremity is the most common, ankle and then knee. About 45% of the injuries in volleyball are non-contact. And then with knee injuries that are being seen in volleyball, you're seeing meniscus injuries, then collateral ligament injuries because a lot of the side-to-side movement and a lot of the landing and compressive forces will lead to meniscal tears. Then you're seeing rotary type injuries like ACL, PCL. Upper extremity is also a common injury with muscle strains being the most common, and that has a lot to do with the fact that they're hitting the ball repeatedly, serving the ball repeatedly, and they're going to get strains dealing with their muscles, as well as hands and fingers. When I was working clinically, saw a lot of thumb and finger injuries on volleyball players because of the setting type activities that they do, and that really tends to sprain or jam fingers. But overall, there's a relatively low incidence of injury, with the majority of them being non-contact, not certainly considered a high-risk sport, and so it's not something where we see a lot of injuries happening. Wrestling, a lot of the injuries here are player contact because of the amount of touching and grappling that goes on with wrestlers. Lower extremity, most common, knee and ankle sprains. But again, a lot of contact injuries in this sport. And the weight class that has the highest incidence are the 142 pounders to 158 pounders. And that's really where most wrestlers fall into anyway, which would make sense on why that's the highest incidence. That's how much most of the wrestlers weigh anyway, and the other ones that are heavier than that or lighter than that really have to work to get to those weights. So we don't have as many wrestlers wrestling in that category. So maybe that's why we're seeing a higher incidence of rate there, as well as just lower extremity injuries. Dermatological conditions are the highest incidence of injuries in practice because there's so much contact that they're having with one another. And so skin on skin, going to get things like ringworm and impetigo and just skin diseases in general. And then the picture in the lower right corner is a picture of cauliflower ear where you're getting fluid within the ear because of the amount of rubbing and friction that happens when you're constantly contacting another player. That swelling can appear in the ear, and that has to get drained and fixed. But really what you're seeing mostly is lower extremity injuries as well as skin conditions and cauliflower ear. So one of the things that also comes out of epidemiological research is you can really start to understand what the risk factors are associated with injury. And you can have extrinsic risk injuries or risk factors, or you can have intrinsic risk factors. Extrinsic to the individual, or something that's on the outside that really can't be controlled by the individual. It's what's acting on them from the outside. So the type of activity, for example, what sport they're playing, what you're doing in that sport. So is it a practice? Is it a game? Is it a high-intensity drill, low-intensity drill? How often do you do that activity? Again, those are things that is not coming from the individual. It's something that the individual has to react to. Environmental factors. Is there humidity? Is there heat? Are they at altitude? Is it cold? Is there a lot of dust? Is there a lot of wind? Those are environmental factors that can lead to injury. Is there equipment associated with the sport? Again, an extrinsic type risk factor. Are you using the equipment? Is it being used correctly? Do you have the right equipment? Does it fit properly? All things that the athlete can't necessarily control internally. It's something that they have to ensure that it's happening. Intrinsic to the individual, which would be age, gender, and psychological mental state, are things that are specifically related to the individual. So how old are you and what's the development? What's your gender, whether you're male or female? And so based on that, you're going to see some issues, and then your psychological or mental state. And I'm going to break these down a little bit in more detail. So what's the skeletal maturity of the athlete? The younger they are, the less skeletal maturity that they have, which could be a good thing, could also be a bad thing. If you're not really skeletally mature, you might be more flexible. You might be able to bend in directions you didn't used to bend. You might be able to jump higher. You might be able to do things and be faster. But you also may not have the strength in your bony matter to deal with the stresses and the demands of the sport. Your ligamentous structures may not be as strong as they are supposed to be when you're not skeletally mature, and that could lead to injury. Depending on how old you are, you might have imbalances between muscle and bone maturity. Now, I had an athlete one time that was so strong, but his body wasn't ready to be that strong. And he ended up tearing his ACL in both knees in 2 consecutive years because his engine was just stronger than the parts, so to speak. His body could not handle the amount of strength that he had. You might have skeletal problems like growth plate injuries or vertebrae fractures or spine issues. You might have femoral issues or femoral growth plate issues with a slipped capital femoral epiphysis. Little leaguer's elbow, where adolescents that are under the age of 14 or 13 are throwing baseballs and they're not throwing with proper mechanics, and because their growth plates have enclosed and because their ligaments aren't as strong as they should be, they end up getting tendonitis or ligament tears in their elbow. And then osteochondritis dissecans, which is just fragments of cartilage or tissues in the joint itself. That's also known as joint mice. Can be seen a lot with adolescents who throw on the lateral side of the elbow because of the repetitive valgus stress that happens when they throw. And so you're getting a little bit more of breakdown on the lateral side of the elbow. And that can lead to problems. So they're not old enough to take on the demands of the sport that they're participating in. We've talked about the female athlete triad with disordered eating and amenorrhea and decreased bone density. That's going to be a factor for those that are female. Males, you're really more dealing with how they mature, not necessarily. What I'm trying to say is that you're looking at the maturation versus the chronological age, that not all boys mature at the same rate. So you can't just say, oh, well, you're 14, so you're good to go. You have to look at their maturity level as well as their growth plates closing and where they are structurally. As far as psychological and mental state, as an athlete becomes more distracted and has decreased focus, then performance is going to suffer. And you're also seeing injury rates increase. So there have been studies that are done that are looking at athletes that are distracted and have decreased focus. What's happening to them? Well, if you're distracted and not focusing very well, your performance is going to be hindered, and you're going to have an increased injury rate. There's a strong relationship between psychological stress and the incidence of injury. So not being sound psychologically can increase the incidence of injury. And then injury may also lead to psychological stress and slow recovery. So psychological stress can lead to injury, and injury can lead to psychological stress. So there's definitely a strong relationship between those two variables. All right, kind of jumping into this workplace and home ergonomics. We talk about this in this class just so that you're aware of what it should look like when you're working, and what ergonomics really is. And ergonomics is looking at the science of designing the job, the equipment, the workplace, so that it fits the worker appropriately, so that you're not increasing the incidence of injury. So you, as someone that's a healthcare professional, might be working in a place where you're charged with this, where you're going to evaluate factors that happen within a job that may increase the incidence of injury, whether it's the way they're sitting, whether it's the job activities that they do, whether it's the lifting that has to take place, and are people lifting properly? If you're working in a hospital, are nurses trained in transferring their patients with good biomechanics and good structures? Are the receptionists in your office sitting the right way? That's going to be something that you might analyze. If your job requires you to do a lot of heavy lifting or stressing the body, are you doing things the way you're supposed to be doing them, and do you have the equipment provided to you to make sure that you're not increasing your chance of injury? So when you do one of these ergonomic risk assessments, you're looking for things like awkward postures or repetitive movements without variation, meaning that you're constantly doing these repetitive things that are always in the same fashion, and you may not be getting the breaks that you need. Are you doing forceful things like this lady up here in the upper right-hand corner who's trying to open up this locker? Pretty forceful. What's going to happen when that locker actually opens? Okay. Awkward postures, again, postures if you're looking at the picture on the lower right, not the greatest work posture to have. Are there forceful movements? Are there vibrations that are happening that can lead to a higher incidence of injury? And then based on that ergonomic risk assessment, you're going to make recommendations on how to make the workplace safer and more effective and lower the incidence of injury. So when you look at an ergonomic risk assessment, there are going to be risk factors that exist in a specific job, and that you know those risk factors based on the assessment that you just did. Can you make physical changes to the job? Can you make administrative changes? Can you maybe do a pre-participation type physical prior to the employee starting work and looking for the types of risk factors that might increase incidence of injury. So if you've got a lot of lifting on your job or the job description, and you've got somebody that comes in that has weak lower extremity, quads, hamstrings, or has had history of back pain, that might get uncovered in a PPE, and then you can teach that person how to lift properly, how much weight can they possibly lift, and put restrictions on them. Maybe they don't have to be lifting. Maybe you can have other people lifting. I mean, there's a lot of water to be carried when you're an athletic trainer, and if I've got a bad back or a bad lower extremity, maybe I need to make adjustments in my work schedule to make sure that I'm not lifting those heavy water jugs. Can I put them on carts? Can I use things? Can I have other assistants to help me do that? And so doing that ergonomic risk assessment will really help decrease the incidence of injury and will allow you to make the job as safe as possible. So it's always better to try and prevent injury than to deal with what happens when the injuries happen. So it's a lot better for us to use our time and resources to prevent injury than to deal with the lost time that goes with injury, the absenteeism, the decreased production, the money that's spent on worker compensation claims. If we can prevent the injury from happening in the first place, then we're going to be better off in the long run. So you may have to spend money up front to do an ergonomic risk assessment, or in athletics, doing a pre-participation exam. You may have to take the time to do that, but if that's going to lead to decreased injuries, then you're going to be better off in the long run. All right, well, that is it for injury surveillance, epidemiology, and ergonomics. Your job now is to go into BbLearn and take the quiz on this lecture, 5-question quiz. It's just going to kind of outline what it is that I talked about today. And since we didn't have class today on 10/28, this watching the PowerPoint and taking the quiz will serve as your attendance for the day in class by watching this video. So thanks for watching, thanks for listening, and I'll see you all on Monday after Halloween.